Okay, so the idea now is to talk about hip imaging. We'll talk about the anatomy of the hip, we'll talk about the blood supply to the hip, and we'll talk about what is the hip. We'll talk about the pelvic bone, which articulates with the proximal femoral part in a articulation part, which is called the acetabulum. We'll talk about the proximal femoral anatomy, which consists the femoral head, neck, basicervical region. We have the intertrochanteric line, greater trochanter, lesser trochanter, subtrochanteric area. Uh, the blood supply to the femoral head will be very important because there is a high risk in fractures, which are especially for those in of the intracapsular type, which uh, cause a very high likelihood for avascular necrosis of the epiphysis of the head of the femur. So let's just start and let's talk about the start with the hip joint. So let's see an illustration. You can see here an illustration of the hip joint. This is the joint that connects the acetabulum to the femoral head, neck. Let's call it the femoral head. So here you have the acetabulum, which consists of the iliac bone, pubic bone, and ischial bone. Those three fuse together as the child uh, getting older, and in an adult, they are fused to form the acetabular region. This is the area which articulate with the femoral head. Here we have some articular cartilage from here and surrounding the femoral head. You will see that there is the ligamentum teres right over here that comes from the transverse ligament and penetrate the articular cartilage to go to the pulvinar of the femoral head, which is the center part of the femoral head. And it's important to note that there is no articular cartilage where the ligamentum teres penetrates the femoral head. So again, we have the iliac bone, the pubic bone, and the ischium, and there are lines. We will see those lines. The iliopectineal line connecting the iliac bone to the pubic bone, the ilioischial line. It's hard to see it right over here, but there are lines that are called based on what bones they connects. Of course, in this joint there is a synovial cavity and head of the femur, neck of the femur, basic cervical region. Basic cervical region is like the cutting point between the area that is considered intracapsular in the femur, which consists the head of the neck, and the extracapsular, which is anything that is distal to the uh, neck of the femur in the proximal femur. So here we have the greater trochanter, the lesser trochanter, intertrochanteric area, and subtrochanteric area. Those are the landmarks that I wanted to show you. Now, let's continue to look a little bit on the acetabulum. And we'll talk a little bit about the bones and everything. So, this is not what I wanted. No, I want acetabulum anatomy. Okay, so let's take this. I didn't think that this is what I wanted, but okay. Okay, that would be fine. Okay, so what you can see, this is the acetabular, the pelvic bone in with the acetabulum, which is the connection between the three bones from which the pelvic bone is constructed. So we have iliac bone right over here, ischium, and a pubic bone and ischial bone, which construct the acetabulum. Now, let's look on acetabular fracture because it will show you the lines. And those are the lines I wanted to show you. Again, iliac, pubic, ischium, femur, acetabulum. And this line, all those lines, or most of them, are important to identify because in fractures, some of the hints that there is a fracture that you may miss is that the lines are disturbed. So this line connects the iliac bone to the pubic bone is called iliopectineal line. This line that connects the iliac bone to the ischium is called ilioischial line. This area here is called the teardrop. This is the acetabular roof. And those are lines that are considered a posterior acetabulum and anterior acetabulum. This is line for the anterior acetabulum and this line for posterior acetabulum. Now also, those are the lines important to note because in fracture you will see that this line can be disturbed and you know that there is a roof involvement. This line can be disturbed, this line. In some variants, we will talk about those lines 1 and 2, which is the anterior acetabular wall, which is 1, and posterior acetabular wall, which is 2, can cross one another, and we will see this. Okay, so after we saw the lines, now we can look on acetabular fractures, and you will see how those lines are disturbed. This is very hard to see something. Let's look at it. Maybe we'll be able to see something. Okay, this is very hard to see right over here. So this is not the best case I wanted to show you. Let's look at another one. Maybe this one. Let's take him. Okay, this one is okay. What you can see, look at this line, the pectineal line. You can see that hop is disappearing. If I show you the lines, and it should be, you see that it should be continuous and very smooth. But in the fracture, you can see that it's just disturbed right over here. And there is a fracture. You may not notice it, but there is a fracture. The roof may also be disturbed. And this is important to note. This is why it is important to note for those lines. So great, we touched on the lines of the hip landmarks. Now let's look at the city of the acetabulum. I want to show you some maybe I'll find over here. Oh, let's look on the hip using CT and let's see how it goes. Now, of course, this is the acetabulum. This is the femoral head going to the neck. We have the greater trochanter right over here, basicervical region. Great. This is probably the area of the lesser trochanter because the iliopsoas muscle comes and insert right over here. Okay, so acetabulum consists again of three bones: iliac, pubic, and ischial bone. This is the ischial spine. Now look at this area. Remember that this imaging is of a normal CT of the hip. So what are you looking at here? Why there is a, let's call it a groove right over here? Is it a fracture? The answer is no, there is no fracture. What you see right over here is the fovea capitis. This is the area in which the ligamentum teres penetrates the femoral head. Remember that the femoral head is covered by a cartilage, but in the area where the ligamentum teres penetrates the femoral head, there is no cartilage. Ligamentum teres comes from the transverse ligament. Transverse ligament sends its fibers and goes into the pulvinar. So this is what we can see, and this is normal. This is not a fracture or something. This is the fovea capitis. This is the groove in which the ligamentum teres, right over here, penetrates the femoral head. Okay, now for a little bit for the muscles, you can see very big muscle here. This is the gluteus maximus. You can see this muscle right over here, the iliopsoas, again coming from two muscles, the iliac muscle and the psoas muscle coming together to be the iliopsoas and inserts in the lesser trochanter. We have also some sartorius right over here and the tensor fascia lata right over here. So the gluteus, gluteus minimus and medius. We have the iliotibial band right over here, gluteus maximus as we said, and what else can I say that is important? Maybe the obturator internus right over here. Those are the main things that I wanted to show you. Okay, so after we saw the normal anatomy of the hip on CT on and a little bit on X-rays, let's talk a little bit about fractures, as we also talked about fractures. And those fractures where you see those lines disturb the iliopectineal line, ilioischial line, roof, the classification of those fractures are based on the Judet and the Tourneur system for classification, which consists of 10 fractures. 5 of them is considered elementary fractures, and 5 of them is considered associated or combined fractures. When we will look on this classification, you will need to note for the anterior column fractures and posterior column fractures. So if we look, for example, on this classification, you will see that there are uh, five types of fractures. When there is a posterior column fracture, anterior column fracture, transverse fracture, and posterior wall fracture and anterior wall fracture. So don't let's call it perplex anterior column and anterior wall, posterior column, posterior wall. Those are different things. You have the wall, which is like in the anterior part of the acetabulum. You have the posterior wall, which is the posterior part of the acetabulum. You have the column, which is right over here. This is the posterior column. You have the anterior column, which is right over here, and each of them is called differently. And you have, of course, the transverse. So those are the basic ones. And then you have the combined ones. You can see that those fractures combines several types, two types. So there are the 5 elementary fractures and there are the 5 combined or associated fractures of the acetabulum. This is the main thing that I'm going to talk about as tabular fracture. Remember that the classification is the Judet-Letourneur classification of the acetabular fractures. Great. Now, from the acetabulum, we are going to go to hip fractures. So let's go to hip fractures. Now, a very important thing to remember is this blood supply and the areas, anatomical areas of the proximal femur. So let's look at the blood supply. You can see that in the blood supply, there is the deep femoral artery, comes right over here, going to be the medial circumflex artery and the lateral circumflex femoral artery. The lateral is the anterior, the medial circumflex femoral artery is the posterior, and the deep femoral artery is the main them, the base of them. Now, as you can see, those coming right over here, this is in the base of the femoral neck. The basic cervical region, which is quite over here, is like the limit. Everything that is intracapsular is right over here until the neck, and this is the reason why intracapsular fracture are more prone to avascular necrosis of the femoral head. The reason is that when there is an intracapsular fracture, the blood supply can easily be disturbed, and the femoral head will go necrosis, osteonecrosis, namely avascular necrosis of the femoral head. Therefore, intracapsular fracture are more prone to AVN compared to extracapsular fractures. Great. Remember the landmarks: head of the femur, neck of the femur, basicervical region, a greater trochanter, lesser trochanter, intertrochanteric area, and subtrochanteric area. Head of the femur and neck of the femur, excluding the basicervical region, are considered intracapsular and are more prone to avascular necrosis. Everything that is extracapsular is less prone to avascular necrosis because it less disturbs the blood supply to the femoral the epiphysis of the femoral head where avascular necrosis happens. And this, you will see the separation to head and neck, where it's intracapsular. The basicervical region is usually considered extracapsular, intertrochanteric area, and extracapsular with intertrochanteric and subtrochanteric area. From the lesser trochanter, take 5 centimeter, and this is the subtrochanteric area. Here, radiopedia includes the basicervical region in the neck, maybe intracapsular, but as I know, basicervical region is considered extracapsular. Now, when I'm talking about capsular, not capsular, what I am talking about? Which capsule? Capsule of the femur. The femur is surrounded by a capsule. You can see here the capsule that surrounds the femur. Everything that's intracapsular is more prone to avascular necrosis. Great. Again, and when you look on a fractures of the femoral head fracture, femoral neck fracture, let's see some of them. And you can see what this is: totally dislocation. Usually it dislocates posteriorly, and in fractures, this is totally posterior dislocation, maybe with a little bit of valgus dislocation. You see that it dislocates laterally. There is valgus fractures and varus fractures. It depends when the femoral head goes to. Let's look at another fracture. This is, of course, fracture of the intertrochanteric area. You see that the lines go throughout the intertrochanteric area. Now, let's stop for a second and call the fracture by their names. We have the femoral neck fractures. The femoral neck, we divide them to valgus fractures and varus based on the angulation of the femoral head after the fracture. When the femoral head goes to this direction, it is considered a varus displacement or varus angulation. And in varus, it is considered, let's call it, non-displaced. I think I made a mistake. The valgus are considered non-displaced. Yes. Okay. The valgus are considered non-displaced and the varus are considered displaced. It depends on where the femoral head goes to. So femoral neck fractures, we're talking about non-displaced or valgus impacted, and femoral neck fracture which are displaced or varus angulated. After this, there is a basicervical fracture, and then we have intertrochanteric, what you can see here, intertrochanteric fracture. Intertrochanteric fractures can be stable with one fracture line or unstable with more than one fracture line commuted. You can see here fracture line here, fracture line here. This is quite unstable fracture. And after this, we have greater trochanteric fractures. And when you see isolated greater trochanteric fractures, note that this is called the tip of the iceberg because usually greater trochanteric fractures comes with a more extensive intertrochanteric fractures that sometimes you will see just greater trochanteric fractures, greater trochanteric fracture without all the other fracture, and then usually on radiographs, and then you should do CT to see, or MRI, which is more sensitive, to see the wall fracture itself. Again, if you see on radiograph, this is radiograph, a greater trochanteric fracture that is isolated, note that this is probably the tip of the iceberg, and you should do a more advanced imaging to look for the other iceberg, the other part of the fracture that can be, for example, intertrochanteric fracture. Now, for the lesser trochanter, the lesser trochanter is connected to the iliopsoas, very strong muscle. I'm not talking about children's, but as adults, lesser isolated lesser trochanteric fractures are considered pathological. Pathological until proven otherwise. What do I mean? That when you see a patient, not this one, but a patient with isolated lesser trochanteric fracture, note that you need to look for pathological reason for this fracture because it shouldn't happen. The iliopsoas is strong, it should just protect the lesser trochanter. So when you see isolated lesser trochanteric fracture, look for tumor, look for metastasis in this region, look for pathological fracture from something. Okay. Also, you need to note that sometimes the radiographs are negative. Let's see if I can show you occult femoral fracture. And you won't see too much on radiograph, but the patient may continue suffer from pain. Okay, so you can see how hard it to see, but you can see on the MRI, those are the T1, you can see quite clearly the fracture line right over here. This is the edema, and probably there is a fracture right over here. You can see that it went to get left dynamic hip screw, but you can see how easily you can miss this fracture right over here. When you are looking, even on CT, it's quite difficult. Maybe this is the fracture. No, it's more proximal. Maybe this is the fracture. It's quite hard. And this is the probably the left. So let's look on the left. Here, quite hard to see any fracture when you are looking in this area. Very hard to see any fracture. So this is why this is in a cold fracture. You can't quite see it. Here you can see fracture, maybe something if you look very hard, but not really. This is in a cold fracture. It will be missed on radiographs. Even CT is not very sensitive. is not enough sensitive to show you this line of fracture, but when you're looking on MRI, you will see this line hypointense area on T1, which is the marrow edema, which means that there is a acute fracture, and this is how it was treated. This is of course a femoral neck fracture, quite prone to avascular necrosis of the head of the femur. Okay, so note that when we are looking on radiographs, there are occlude fractures, and this is very, very disturbing. So now let's look a little bit about the femoral neck fracture more closely. Okay, remember the intratrochlear part of it. Now, I'm not going into the transcervical and everything, but we have the intratrochlear fractures, the subtrochlear fractures which are extracapsular, and capital, subcapital, and transcervical. Let's call it the just head or neck of the femur fractures, which are intracapsular. This is the blood supply again. Um, Deep femoral artery, medial circumflex femoral artery, and lateral circumflex femoral artery. This is our blood supply that we are talking about. Okay, capital is the head, subcapital is of the neck, and transcervical right over here. So, oh, no. So, when we are looking here, we can see, of course, a femoral neck fracture that going to this side, which means it's an valgus angulation, which is considered quite non-displaced. So this is impacted subcapital femoral fracture of the left femoral neck. Subcapsular fractures. You can see just over here, it going, let's call it valgus direction. This is of course displaced fracture of the femoral neck, very, very prone to avascular necrosis. You have a varus angulation of the femoral head. This is totally displaced. Okay, so we saw a little bit about femoral neck fracture. Let's see if we can even see basic cervical fracture. Let's see if I will get something. Radiopedia. Okay, so you can see right over here the basic cervical region is, of course, here it considered intracapsular the basic cervical. Okay, there is a little bit debate about the basic cervical. You can see here the basic cervical fracture. It will go to get the ORIF or dynamic hip screw. Now let's look at greater trochanteric fracture. Again, what is very, very radiopedia? What is interesting on those? I say again, on those fractures, that when you look on a greater trochanteric fracture, you need to think that it may be the tip of the iceberg. And maybe I will see something that will let me show you Okay, it won't let me, but you can see here the intraorthopedic fracture. But what I wanted to show you is that greater traumatic fractures should be thought of as something that may be the tip of the iceberg, and you should look for something more extensive. You can see isolated greater traumatic fracture, um, maybe. Okay, it doesn't show me this. Okay, so let's continue. Intertrochanteric fracture is what we saw. Intertrochanteric fractures is what we saw. You can see right over here the intertrochanteric fracture. Probably you get some screw or nailing or for screw. Okay, let's go to the subtrochanteric fracture. This is again an extracapsular fracture. Okay. Now you need to note that there are also stress fractures. For example, of the neck of the femur. And when you see such fracture, you need to think about someone that is, you can see right over here, with bone marrow edema. Those are on PD, fat saturation imaging. You can see this stress fracture right over here with bone marrow edema. And you need to think about, for example, someone that is on high physical stress, like athletes, active patients, or maybe female athlete with the triad of disorder eating, menstrual dysfunction, and low bone density. Those are also prone to those stress fractures. But you can see right over here the femoral neck stress fracture with bone marrow edema surrounding it. Okay, now a very important fracture we'll talk about is atypical femoral fracture. Atypical femoral fracture are very subtle initially, very subtle, but can get very, let's call it, very bad with time if not identified early. And you can see here how bad it can be. You can see here how it can get to. But initially, those fractures are very subtle. Those are a what is called insufficient fractures. Namely, you will look for them, for example, in older patients, but sometimes it is very hard to see, and this is a fantastic example because what you see is just this very little, uh, let's call it remodeling or very subtle thickening of the cortex that you may miss, but this is a typical femoral fracture. Subtle, but very important because it can totally break. Now, it can also be in patients on bisphosphonates, everything that makes the remodeling of the bone problematic, namely damaging the osteoclast and not letting the bone remodel as it should, may cause the patient to be more susceptible to this atypical femoral fracture. And this very subtle finding, oh, here you see bisphosphonate. This very subtle finding can get to the very bad, the very bad fracture you see right over here. Again, bisphosphonate induced femoral fracture. And this is how it ends with nailing, intramedullary nailing, ORIF, with ORIF. Okay, now let's look at another thing. We talked about avascular necrosis of the femoral head. Avascular necrosis of the femoral head. Osteonecrosis is another name for avascular necrosis. Again, we said that it may be traumatic from intracapsular fractures, or it may be atraumatic for something that may cause the blood supply to be not so good to the femoral head, like a, how it is called, sickle cell disease, because the sickle blood vessel, the sickle red blood cells, can not get to the femoral head, to the epiphysis of the femoral head, and is cause ischemia to the femoral head, and by that osteonecrosis, or another name for avascular necrosis. Other things are like Gaucher disease. In children, we can talk about Pertus disease, idiopathic osteonecrosis. Okay. Okay, so in avascular necrosis, it's not very easy to see this on radiographs. Very subtle findings. Oh, this is not what I wanted. Very subtle findings. Okay, so you can see right over here, let's call it in the left hip. You can see how subtle it is. Okay, so it was removed. Okay, so here it's very hard, but there is a higher radio opaque in the femoral head. It's more sclerotic, and this sclerotic area is the hint for avascular necrosis. Quite hard to see and to note. Quite hard, but there is some sclerosis. There may be some irregularity of the subchondral area. Quite hard to see. Quite hard to see. Yeah, but this, what can we say? Femoral. Let's call it the hip radiograph. Just for you to, I don't know, compare. Wait, not this one. This one. Compare this irregularity a little bit and sclerotic area right over here to this normal radiograph. You can see that it is more smooth. There is no radio opaque area on the subchondral area. When you look on this one, or not on this one, you see that it's more curved, less smooth head, more sclerotic. This is very hard to see. I must say this is very hard to see. When you get to a MRI, when you get to MRI, what you may see, not very easy, but there is what is called double line sign that you can see on T2 weighted imaging, that this is for someone with lupus. For example, this one, you can see it here. It's not very easy, but it is considered a pathognomonic finding for a osteonecrosis. What you will see is two separated lines, an inner bright line and an outer dark line. Now, it's not very easy but to see, but let's call it inner bright line and outer more dark line. It's not very easy to see. It should be on T2, so let's look on steer, axial T2, inner bright line and outer more dark line. It's not very easy to see. It's not very easy to see. You need not to confuse it with the rim sign. This is avascular necrosis. Again, this is the lines, but it's not very easy to see. Bright and dark line. Not very easy to see these things. Again, avascular necrosis. Not very easy to see. Okay. What else do I want to say? Okay. Another thing for atypical fracture that we talked about with the femur is that when you see like biphosphonate induced atypical femoral fracture, you need to image also the contralateral leg because there may be bilateral atypical femoral fractures. Now, after we talked about the avascular necrosis, let's look a little bit on femoroacetabular impingement. Femoroacetabular impingement, let's call it a variant that may predispose, and I say may predispose to labral tears of the femoral head. And there are two deformities for femoroacetabular impingement syndrome. There is the cam deformity, when you can see it's more convex right over here compared to this normal proximal femoral. It's more convex right over here, and this is the cam deformity. And we have Pinker deformity, and maybe you show me the Pinker deformity. Okay, so looking here, Pinker deformity. And those two deformities, the cam that we just saw and the Pinker, okay, you can see the cam where the femoral neck is more convex, is more prominent, and the Pinker where the acetabular area is more sharp and more distal compared to not. It can be combined, it can be isolated of the two, and this umbrella of things is called femoroacetabular impingement because those things can predispose to labral tear. It not must. People can be with those variants and be asymptomatic and normal, but those can be seen on radiographs, can be seen on symptomatic patients, and when the patient are symptomatic with complication, it's called the femoroacetabular impingement with its complication. When we are talking about cam impingement, let's see if there is a radiopedia, we can calculate what is called the alpha angle. I'm not sure that radiopedia show this, but alpha angle cam deformity, which when it is more than 55 degrees, it is considered abnormal. I'm not sure that they show the alpha angle very good, but let's look at it. Where is that? Okay, you can see right over here the bump, which is the, let's call it the cam deformity, but where are the calculations of, okay, you can see here, you take the line from the start of the bump, the start of the cam deformity, and you take a line from the center of the femur. You connect those two lines and you calculate the they are calculating this alpha, but I know that you are calculating this alpha. I don't know why. Anyway, yes, you are calculating this angle. This is called the alpha angle. I think they just write it over here, and by they mean to this angle right over here. And this is 85%. I think they got. Anything above 55 is considered abnormal. That's it. Okay, 55. There, here they say 50. Okay. Okay, and this is for cam deformity where there is a bump on the femoral neck. Now, when we are talking about pinker deformity, what you may see is it's not very easy, but what you may see is the anterior acetabulum and posterior acetabulum cross here and here. You see that instead of, let's show normal hip orthopedia, instead of, okay, being here and here, those two lines, what is called the anterior acetabulum and posterior acetabulum, quite hard to see, but it's right over here and right over here. What you can see in pinker that they quite cross. I mean, the anterior acetabulum come right over here and get to this area, and the posterior acetabulum goes and cross it. Quite hard to see, but anyway, this is the crossover sign. Maybe there is crossover sign on pinker Wikipedia. Maybe there will be a better illustration. Okay, so you can see that they cross over each other, what should not happen. And this crossover indicates acetabular retroversion for femoroacetabular impingement for pinker type deformity. Not very easy to see, I must say, not very easy to see. Okay, here is the most easiest part to see this crossover, I think, because you continue with this, you continue with this, and you feel, let's call it, the you can feel the, let's call it, the pinker deformity. Now let's go to labral tears, or let's start with labrum of the hip. So You can see the labrum of the hip, which is surrounds the hip socket, and we will talk about labral hip and labral cartilage tears. You can see the labrum right over here with tears that can be. So, Radipedia. Oh, I want tears. Okay, so we have the labrum that you just saw, and sometimes what we can see are labral tears. That's what I want. You can see the tear right over here, but I want not case, article. Great. So you can see the tears, especially when there is a MR arthrography with injecting of contrast into the joint, which this is for cam deformity, and this is here the labrum. You can see the material, the hyperintense material getting inside the labrum. So this is the labral tear. Not so easy to see sometimes, and you should not confuse it with sulcus or sublabral sulcus, because sublabral sulcus is a normal thing, and you should not confuse it with this. Let's look at another labral tear. This is the area. It's quite not. You see this area with the labral tear right over here. On T1, probably injecting some ultrasound as we saw. Sometimes there are cysts, paralabral cysts, as you can see right over here, that develop. Okay, so the problem is on the right. Here you can see the cyst. This is another sign that there is a tear right over here. The cyst just took the synovial fluid. Anterolabral tear and paralabral cyst. Okay, so this is it about imaging of the hip. Very superficially, I just wanted to, let's call it, tell you the main subjects on hip imaging, and I didn't get too deep inside on every subject, but I wish that as we started with the anatomy of the pelvic bone, and then we concentrated to that tabulum, which constitute the iliac, ischium, and pubic bone, We talked about the lines, which are important for identifying fractures, and we talked about the muscles around. We talked about the hip joint, which is the joint between the acetabulum and the femoral head. Um, we talked about the anatomy there with the labrum and the cartilage, and the anatomy of the femoral, proximal femoral part with the head, neck, basicervical region, intratrochanteric area, greater trochanter, lesser trochanter, subtrochanteric area. We talked about intracapsular area compared to extracapsular area, which is important because avascular necrosis happens more commonly in intracapsular fractures, namely head or neck fractures, and the basicervical region is the limit. Some tell it it's extracapsular, some say it's intracapsular, or probably it's extra, even though Orthopedics says intracapsular. I don't know. Basicervical region is the limit. So we saw fracture of the acetabulum. We talked about the classification with the 10 types of fractures. 5 of them are elementary: anterior column, anterior wall, posterior column, posterior wall, and transverse and everything. And we talk about the associated fractures or combined fractures of the acetabulum. Then we went to talk about the femoral, proximal femoral fracture with head fractures or neck fractures, intertrochanteric fractures, greater trochanteric fractures that may be the tip of the iceberg, isolated lesser trochanteric fractures which should be considered pathological until proven otherwise, the subtrochanteric fractures. We talked about atypical fracture that may happen for example, bisphosphonates. We talked about labral tears, or before this, we talked about femoroacetabular impingement, which consists of two deformities, cam and pincer. Cam is in the neck of the femur and pincer on the acetabulum. They can be combined and they may predispose those young athletes to labral tears, or they may be asymptomatic and totally asymptomatic. And we talked about stress fracture of the neck of the femur, especially in women athletes with the triad of athlete and eating disorder and menstrual disorder that may cause femoral neck fracture in those active patients or active young athletes. As you can see, the bone marrow edema and the hypointense line in the center of it. We talked about the idea that femoral fractures or proximal femoral fractures may be occult and the radiographs are totally fine. Even it's hard to see in CT, but on MRI, you can see the low intensity on, for example, T1, which represents bone marrow edema, that can tell you that there is a fracture that you just missed, occult fracture. So beware with those femoral proximal femoral fracture they may be occult on radiographs. So this is it about hip imaging. Thank you very much. I know that it was superficial and not deep. Sorry, but I mainly wanted to talk about the main topics. Thank you very much. If there are any mistakes or correction, please tell me. Thanks a lot to Radiopedia. I used it, as you saw and as you can see right over here, quite a lot. And this was about hip imaging. Thank you very much. And that's it.